Thank you. Well, I'm going to be talking about cancer prevention and control in adolescent and young adult survivors. And notice I renamed my talk because actually I had a division of cancer prevention and control. And of course, we're trying to screen and detect cancers early in the general population, people at risk, but also survivors are the target of this. So I'm going to be talking about issues related to surveillance for recurrence in survivors, and you already heard from Kevin the high risk, but also second cancers. So why focus on surveillance for cancer recurrence and secondary cancers in AYA survivors? Is the first point I'm going to cover. What exposures and other factors put them at risk for another episode of cancer? And then why and how should we be monitoring, screening, and doing prevention in the AYA survivor population, and the clinical and policy implications of this. So you've heard this from almost each session, which is the heterogeneity, not only in terms of age, distribution, developmental stage, but really the types of cancers and prognoses. It's a big wastebasket. And of course, we have people presenting with late-stage disease because of lack of insurance or access to care, but also tumors that may present just advanced disease because of where they are. On the broad age range, and again, the thing that really kind of drives me to an interest in this population is the number of years of life potentially to save if we pick up a recurrence early and it's treated, and if we detect and screen for those second cancers. So this is a group of individuals who have a long life ahead of them, and really cancer and these other chronic conditions are their main threats. So if we can do a better job of this, it's an opportunity for us. And again, it's a very high-risk population. So we really need to think about the value of prevention in this group. So this is just to show you the heterogeneity of this group, and I probably have left off a few tumors, but it's many different types occurring at different ages. And the issues that I think of as an adult oncologist, which is what I am trained to be, is that the groups of tumors that you see in this group of patients really kind of come in two flavors. It's not to say we don't see the same in adults, but some tumors are very rapid growing. If you think about high-grade Burkitt's lymphoma, some of the other high-grade lymphomas, leukemias, very aggressive diseases with fast-growing cells that, again, are often widely disseminated. But then you may have very localized low-grade sarcomas that are going to be causing most of their trouble with local recurrence. Did you remove it completely? Did you give radiation? And then the kinds of issues in terms of the morbidity and relationships to the tumor and where it's removed. So really the frequency and intensity and the type of monitoring that you're going to do for recurrence kind of depends on whether this is a rapid growing tumor that I expect lung metastases to occur, or is this something where I have to really look for a local recurrence. I think the other thing that we really suffer from, and it's common in all age groups, but I think particularly in this group of patients, is really the paucity of evidence-based guidelines. We do have some disease-specific strategies, of course, because we've had remarkable curative therapy for testis cancer. The investigators around the world who have studied and followed these patients have really developed consistent ways of following these patients with tumor markers and with scans and so forth. But for many of the other diseases, there isn't as much consistency. So we really need to find a way to improve upon this. And again, the issue in terms of recurrent surveillance, that is, how quickly and how soon after somebody's had curative therapy do we continue to do intensive surveillance, really depends on the timing of when we expect the recurrence. Because for some cancers, like the high-grade lymphomas or the sarcomas, we're going to expect a recurrence in the first 18 to 24 months. And if we haven't gotten a recurrence in that point in time, we're probably going to be less likely to do that, whereas other slower growing cancers may have late recurrences many years later. So again, how you do your strategy depends not only on the type of the cancer, but its grade and its presentation and so forth. So again, the heterogeneity of all these tumors makes it difficult for me to come up with a very easy guideline or recommendation. This is a little bit more of the same. If the recurrence is more likely to be local rather than metastatic, you're going to do careful clinical examinations and scans looking at the local area, and you may do tumor markers. But again, if it's going to be more widespread, like the hematologic malignancies, you may be doing PET-CT scans, you may do blood and other imaging markers. So again, depending on the type of tumor and its pattern of relapse and recurrence, the surveillance strategy should be tailored to that. So again, kind of my passion for thinking about this group of vulnerable individuals is that they have very few competing causes of death. And I'm going to show you some data on breast cancer more specifically. And really, recurrent cancer is the most significant threat for them. So having a good and well-informed surveillance strategy to look for recurrence and hopefully to successfully treat those individuals after they recur is really the goal of recurrent surveillance. And again, I've given a few examples where detecting recurrence for germ cell tumors, Hodgkin's lymphoma, thyroid, high-grade non-Hodgkin's lymphoma. Maybe I should put leukemia down there as well, although I was less optimistic about that. But maybe with transplant, that's okay. But in any case, again, if we can detect these recurrences earlier, hopefully we'll have a better chance of curing these individuals. So this is just to kind of show us in breast cancer, which is the area that I work in primarily, and to show you we have something called the Oxford Overview, or the Early Breast Cancer Trialists, who have come together and probably have over 100,000 individual cases for a meta-analysis where they can look at large subgroups of patients. And this was the 15-year analysis for women less than 45 with ER-positive tumors. And these women have almost all had chemotherapy, but we are comparing here tamoxifen versus control, and you can see how important tamoxifen has been in terms of delaying recurrence. But the sad thing here is there's still a 35% recurrence in these women under age 45 for breast cancer. And again, here, if we look at survival, it's the same thing. 25% of them, again, are going to have a mortality after breast cancer. And if we look at what's causing death, very few of these women are having a death associated with another disease. Almost all of the deaths related to recurrence are due to breast cancer. So identifying those recurrences is very important, and obviously treating them. I would say, though, actually in breast cancer, we have a harder time curing those recurrences. We don't have the highly effective therapy that people have for some of the faster growing neoplasms. So what do we know about surveillance testing after breast cancer? And this is kind of one of those middle ground cancers where if we detect a local recurrence, we can probably invoke therapies that might cure those individuals. But with metastatic disease, we're more likely going to have to be controlling the disease. We're not going to be curing it. So what happened was that based on the analyses of outcomes from breast cancer adjuvant therapy trials, when again I started my career, we were doing bone scans annually, we were doing chest x-rays, we were doing blood tests every 3 to 4 months. And what they did was look back retrospectively and saw that almost no recurrences were discovered in our clinical trial patient population without the patient being symptomatic. So in our clinical trials, we abandoned routine screening, surveillance testing to look for recurrence in breast cancer. So that's on a clinical trial. There were also 2 randomized controlled trials conducted in Italy in the late 1980s and early 1990s that were published in JAMA. And these particular studies used different intensity of surveillance tracking after a breast cancer diagnosis versus usual care, where the woman just came in for a visit, and if she had a complaint, she would be then subjected to various tests. And they found no difference in survival between those 2 arms. One of the studies actually looked at quality of life, and there was no difference in the quality of life in the women who were intensively surveilled versus not. So based on that and a Cochrane review, these tests were discouraged, and I'll show you some of the guidelines related to that. So what about tumor markers in breast cancer? And again, we have tumor markers available. They're nowhere near as good as with testis cancer. There's not an equivalent association. Sometimes they're negative when the patient has recurrence, and sometimes they're false positives. And there have actually been no RCT data showing any value to using tumor markers in breast cancer follow-up, although I could tell you that a large number of physicians in this country order them. And the rate of false negative or false positive findings are not known. And then a normal or abnormal result can contribute to false reassurance and or increased anxiety in our patients, as well as unnecessary evaluations. And all you need to do is get a little rise in one of these tests, and a woman is on a tailspin of having PET CTs, MRIs, you name it, and then somebody will see a little something on the CT or the MRI and say, well, we need to follow that up, when it's really nothing. So what about imaging tests? The data here are, again, very sparse. Chest and abdominal CT scans or whole body PET scans have not been subjected to any evaluation, but again, they're sometimes commonly done. They're certainly done for staging where we don't have much data. And with the low prevalence of distant recurrence, especially in early stage breast cancer, I'm talking about women with very small tumors or negative nodes, there's no evidence to support the use of routine imaging. But again, we do have these being conducted. So as a result of these findings from the randomized trials and the lack of evidence for this, the recommendations that we have are that patients should be carefully screened with clinical examination. We should be looking for an ipsilateral, that is the same breast recurrence if the woman has had breast conserving surgery, or a new primary that might be occurring in the breast, because women can get multiple breast cancers, and certainly the contralateral breast needs to be looked at. So clinical breast examination and mammograms are important for screening and detecting local recurrence and new primaries. Breast MRI screening, while we would say, okay, if mammography doesn't catch everything, we need to add MRI. But again, there's a high rate of false positives there. And we really recommend this kind of screening only for BRCA1 and 2 mutation carriers. So we really have a challenge here because the low-tech procedures are the ones that are recommended, but we actually don't have full adherence to mammography screening and clinical breast examination in breast cancer survivors. And as part of looking at what is appropriate in terms of the kinds of testing that we as an oncology community should be encouraging, again, this is an example for breast. This was number 4 of ASCO's recommendations of a top 5 list of things that could be recommended, which was that we don't perform surveillance testing with biomarkers or imaging or radionuclide scans in asymptomatic individuals who have early stage breast cancer, and this is part of the Choosing Wisely campaign. But again, I'm talking about an example. Again, as Kevin mentioned, this is 50% of the women who are AYA patients and survivors with breast cancer, that we don't have evidence for the value of this, and we can make definitive recommendations. But for a lot of the other diseases that are common in this age group, we don't have some. I'm happy to see, though, that there was a presentation at ASCO looking at lymphoma follow-up, and we're now beginning to see it in other diseases where people are beginning to back away from recommending these surveillance tests for which we do not have evidence of value, and as I'll talk about in a little bit, there may be harm. So what factors increase the likelihood of second cancers, that is, cancers that are not a recurrence but a completely new malignancy? And as Kevin mentioned earlier, 16% of new cancers every year out of those 1.6 million are actually from people who've had a cancer before. And I think I can't emphasize enough that in the AYA population, many of these individuals may have hereditary predisposition genes. And of the patients that I see in my survivorship clinic, many of them who had cancer diagnosed at a young age, the thought that there could be a familial predisposition has not been always attended to in looking at those individuals. Treatment exposures such as radiation and chemotherapy, and then the risks from diagnostic imaging procedures, which again I want to talk about because I think this is an important area that hasn't been explored as much as it should be. So in terms of hereditary predisposition for cancer, I have probably not listed everything, but the Li-Fraumeni syndrome, which accounts for mutations in the p53 gene. Again, you can see a wide array of cancers. Again, leukemia, sarcoma, brain and breast cancers occurring at a young age, adrenocortical carcinomas. And again, taking a family history, identifying that this person is in a family where there is a predisposition may be very important in terms of then discovering the mutation and then screening them for the risk of these other cancers. HNPCC, or Lynch syndrome, is, again, usually associated with colon cancer at an early age, but it's also associated with uterine cancer, ovarian cancer, and urinary tract cancers, other cancers. And so again, if you had an individual at a young age diagnosed with colon cancer, take the family history, get the testing. You can test actually the tumor to see if there's any evidence of the mutations, and then you can in fact do a prophylactic hysterectomy in a woman who may be a carrier of one of these genes. FAP, again, another common cause for cancer in young adults, and BRCA1 and 2 mutation carriers, again, many of those young breast cancer patient survivors we see have a BRCA1 or 2 mutation. If you don't think about it and test it, you will not be able to prevent perhaps a second breast cancer by preventive interventions or reducing the risk of ovarian cancer, and then a number of other cancers that may occur in association with these genes. So again, almost all of these hereditary predisposition syndromes are associated with cancers that are occurring in the AYA population. So get to know your geneticist, get to know the people who are doing this kind of work. So again, recognizing the syndrome is really important, and there's such a great opportunity to do secondary prevention, and again, risk-reducing surgery and intensive surveillance for most of these predispositions syndromes are very well established, and there are guidelines for them. So in terms of treatment exposures, radiation has really probably been the most important, although chemotherapy alone and chemotherapy and radiation together are important. And again, most of the radiation late malignancies are 10 to 20 years later, so they're many years after the person's been exposed. And again, I won't go into a lot of detail here, but in general, it's in the port of the radiation field in which we see these cancers occurring. And again, thyroid cancer being very common. You've already seen Kevin's data on breast cancer risk, GI tract cancers in people who've had chest and abdominal cancers, and then the basal cell cancers in the field. And again, something that I learned by hearing an advocate talk about her experience was from the radioiodine therapy that individuals receive for thyroid cancer. If you do not get a laxative, the iodine sits in the gut, and there's a high risk of GI malignancies. Again, very important. I'm not sure that our colleagues who give the radioiodine are as aware of that. And again, just to show you, you have to know what the dose in field was that the individual, the parts of the body affected, and again, be thinking about this downstream. And again, for total body irradiation and radioimmunotherapy, again, there may be different risks that are occurring. And again, I just want to show the Children's Oncology Group. This is an example just taken from one of their pages. I have the source up there. They have excellent guidelines. Again, although focused on children, I think we can probably extrapolate some of these to adults. This is a paper reporting on the treatment-specific risks of second malignancies and cardiovascular disease and testicular cancer. And again, just to show you here, the seminomas are the patients who primarily got radiation, but if you have radiation and chemotherapy together, there's a 10 times difference in cumulative risk. And again, they had a general population comparison group. So again, we need to be thinking about the particular exposure in many different diseases. In chemotherapy, we need to look at the leukemia risk. Those are often occurring earlier. MDS and non-Hodgkin's lymphoma are some of the risks that we need to think about. And then other risks such as bladder cancer from cyclophosphamide. I wanted to present some data. This was presented at the ASCO Quality of Care meeting last year, and I want to go through this abstract because I was actually the discussant on this paper, and it was I just contacted the authors. They have not published this as yet, but what they did was look at a population-based cohort in Ontario, Canada, where they identified individuals with a cancer diagnosis who were 20 to 44 years of age at diagnosis, and they had to be at least 5 years disease-free when they came into this cohort for study, and they matched them 1 to 5 to a population control sample of young adults. And they looked at the number of imaging services that each group had based on claims data, and then they estimated the dose of radiation from the CT scans that were done. And you can see they had 20,000 survivors and a median follow-up of 14 years. So this was a very large observational study. What you can see here is many higher rates of having CT scans, a number per year, 0.3 total compared to control for the CT, 0.65 versus 0.47 for the ultrasounds. But if you look by individual diseases, look down at the very bottom, non-Hodgkin lymphoma, 0.73 versus 0.09 for those individuals. Again, almost one CT scan again. And these are on individuals who are more than 5 years after their initial diagnosis and are disease-free. This is looking at the rate ratios for the CT scans, and again, overall, for all the total cancers, it was 3.5, but again, if you look at non-Hodgkin's lymphoma and Hodgkin's lymphoma, you have 0.7 and 8.5 rates, so again, very, very high rates of having additional scans, additional radiation exposure, and these investigators estimated that these recurrence-free survivors received a mean dose of 24 millisieverts, which would be the equivalent of about 1,300 chest x-rays in terms of radiation exposure. And again, a significant increase in terms of dose compared to controls. So some questions raised by this study is, why are these disease-free AYAs having, long-term survivors having so many imaging studies? They're disease-free, and yes, maybe there's a late risk of recurrence, but why? How can we reduce the number of these unnecessary procedures and increased radiation exposure? Will explicit survivorship care plans make a difference in terms of reducing the anxiety perhaps for the family physician or the patient in terms of what needs to be done? And how effective will guidelines be in reducing this unnecessary testing? And I would venture to say if this is happening in Canada, it's probably at least as bad or worse in the United States. So monitoring, screening, and prevention strategies for the AYA population, what should we be doing? Well, one of the big problems is who is taking charge. And I think we know that from the IOM's survivorship report that for post-treatment care, there's really very poor coordination that's going on. It's probably even worse for the AYA survivor who's very mobile. They may have gone off to college. They may have moved away from their family. They're not anywhere near where they got treated. And I think we need care plans, and we need to do a lot of other things to coordinate this care and really to avoid the unnecessary imaging and radiation exposure that I pointed out. We need to do it with good, clear guidelines. And we need to really educate and empower the AYA survivor. As much as they may want to forget about their cancer experience and want to be just like everyone else, I think they do come to the realization sooner or later that this is with them and this is part of their history. And I think the sooner that we have guidelines that can be very clear and not one doctor saying this and another doctor saying that, we can, in fact, give this to them. We can post it online. They can access it, and they can know what they need to do. And then I think we need to do something to improve the uptake of prevention strategies. We clearly need to educate primary care providers who may be following these patients who have a long-term past history of exposure about things that we can do for risk reduction, obviously the tobacco control exposure, obesity things, and I'll speak to that in a minute. And I think we need to identify high-risk groups within this population and really provide them with counseling. And the high-risk groups are the ones that we know are at really high risk of these second malignancies. So some of the clinical and policy implications, I think urgently needed. We have to have the development of an evidence base for recurrent surveillance. We do not have to have the perfect be the enemy of the good. We could go back and look at clinical trials that have treated these patients and look and see whether intensive surveillance actually made any difference. That's essentially what the people did in terms of their presentation lymphoma. They looked back to see if those scans actually did any good. We have to have the rational use of imaging tests with limitation of radiation exposure because there's already a substantial body of literature just in the pediatric population where a lot of these tests are being done and are inducing additional cancers. And it may be that we don't necessarily have to eliminate these scans, but they don't have to be done every 3 months. And if an abnormality has been stable, we don't need to follow it forever. So I think somebody kind of just stepping back and saying, what's the use of doing this just because the radiologist told me it needs to be followed? Is it adding to the value of the care that I'm giving? And I think we don't necessarily have to have rigid guidelines, but certainly guidance statements on recurrent surveillance for the most common AYA cancers could be a real step forward. Secondly, I think we need standardized approaches to screening for second malignancies in this group of individuals. As I've already shown you, many of them are at very high risk either because of genetic predisposition or the exposures that they've had. And I would think about extending those COG guidelines, or consider using something like that as a first best approach to begin to implement something in this population, since there's probably a lot of overlap in terms of diseases. And then really to recognize and test for genetic predisposition and put that high up on the radar screen. In diseases where we have multiple organ-based primaries, such as breast or colon cancers, the colon is left intact. If you have HNPCC, you have to be screened again. Even if you have just plain old colon cancer without a genetic predisposition, we need to do this the same for breast. And as I've already mentioned, many individuals are not getting that kind of follow-up. And then we have to actively pursue risk reduction strategies. And I think we need to think about chemo prevention. Sadly, in the Hodgkin's lymphoma or other chest radiation patients that Kevin has so nicely shown us has a very high risk, there's very limited uptake of tamoxifen in that population. And so we really need to think about how we can get the message out and have this be a more standardized approach. And then finally, we need to implement behavioral and lifestyle risk factor reduction strategies, because again, this is generic for the population in general, generic for older cancer survivors, but as I've already shown you, this is a very high-risk population that's going to die from either their recurrent cancer or a second cancer experience if we don't do something to reduce this. And again, these are all the environmental exposures that we need to address. SERMs, as I've mentioned, after chest radiation exposure, and management of energy balance, again, to reduce obesity and increase physical activity. And there needs to be very good, strong collaboration with primary care providers. We have one, at least in the audience, Larissa, but we need to get the word out to the generalists who, in the prevalence survey that Robin reported, all of those people are most likely under the care of primary care providers, and they need to have this message as well. So we need to do something to be able to manage this vulnerable population. Thank you very much.